Obviously, it's, the proctor loves this. Good stuff to know, right? More meds. Let's do this. Okay, bipolar. Okay. What is bipolar disorder? Okay, so it's a new DSM-5 category. Excuse me. So mood disorders with recurrent episodes of depression and mania. Okay, we're going to talk about mania. We're going to talk about the signs and symptoms that qualify one to be deemed manic. Mania, excessive elevated mood, and depression. Same signs and symptoms that we discussed last week that had to do with depression. Same thing. Okay, so mood disorders, recurrent episodes of depression and mania usually emerge in early adulthood with an early onset. Okay, we with our bipolar patients, when we initially diagnose them, they're always in their young adult age. Okay, 20s. Sometimes they start, well, not sometimes, a lot of the times they present with manic symptoms, which we will discuss the different types of manic symptoms. They present maybe in late teens, and then as soon as they hit adulthood, we actually diagnose them with bipolar disorder. Okay, periods of normal functioning alternate with periods of illness, though some clients are not able to maintain full and occupational social functioning. So it's not like our bipolar patients are constantly manic. That's not the case. They have mood, they have periods of actual normal functioning, and then they alternate from mania and depression. Okay, a lot of people have very successful lives with bipolar disorder. Clients can exhibit psychotic, paranoid, and bizarre behavior during periods of mania and other different types of manic behavior that we will discuss. Okay, so that's bipolar disorder. Let's move forward. So this is a slide of. Have you guys seen this show, Homeland? Anybody? Yes? No? Excuse me. It's a very, very. I mean, it's an awesome show. The main character has bipolar disorder. I mean, she actually studied bipolar patients to play this character, and she does look at some scenes. There's so many scenes where she's actually going through active mania, and it's just perfect. Okay, the show is called Homeland. Homeland, check it out. You're gonna like it a lot. And obviously, you guys know a lot of celebs come out with their diagnosis. You guys know Britney's diagnosed. Is that Jim Carrey? Jim Carrey, Mariah, Demi. Demi has a whole documentary on her mental health situation. I don't know if you guys are aware of it. Check it out. Check it out. There was this one scene in her documentary where she said her manic episodes where she wouldn't sleep or eat for days, and all she would do was write music. That was her form of mania. She wasn't combative, she wasn't like aggressive. It was just not sleeping, not eating, and writing music for days and days and days and days. Of course, she had drug history and all that stuff. It's quite interesting. Check it out when you get the chance. Catherine Zeta-Jones belongs in this category. I'm sure there are lots of celebrities I'm not aware. Yeah. So, before we even reach what the signs and symptoms of mania are, patient care. Okay, care of a client who has bipolar will mirror the disease that the client is experiencing. Obviously, we care for the patient. Our care for the patient mirrors what they're going through. Yes, of course I can. Here it is. You're welcome. You'll enjoy it. I think it's on Hulu, if I'm not mistaken. Okay, so there's acute phase, continuation, and maintenance phase. Let's start with acute, okay? This is the manic phase, okay? The manic phase, again, I know we don't really understand maybe what some signs and symptoms of mania are, but we're gonna get to it in the following slides, okay? So, mania. So this is where your patient has to be hospitalized, okay? They can't be on their own. And when they're hospitalized during this phase, remember safety and psych is priority. They're on a one-to-one, okay? it's a safer, so possible SI, right? Danger to self, danger to others. Hospitalization is required. Reduction of mania and client safety is the goal, right? There you are, one-to-one. Risk for harm of self to others, one-on-one supervision. And by the way, this is where we start them on meds. Okay, we're going to talk about lithium today. This is where it begins. Okay, this is where it begins. And then we've got the continuation phase. Kind of generally 4 to 9 months in duration. Such a long time, right? Hopefully at this point we've reached therapeutic level of lithium to keep the mania stable. We're going to talk about it. Remember, it's 4 to 9 months, give or take, depending on how compliant your patient is, right? Relapse prevention through education, medication compliance, psychotherapy. We never just discharge our patient cold turkey, right? Hey, you can go, right? We still provide medical care, we still educate them, therapy, meds, all that stuff. And then we've got maintenance, which means our patient who has bipolar disorder has to be on meds their entire life. Prevention of future manic episodes is the goal. That's the point. That's the point. We're going to talk about, right? We're going to talk about certain triggers later on, but that's the point. Once you discharge your patient, the whole point is to educate them and tell them, hey, like if you don't take your meds, you can relapse. If there is some certain trigger, which we're gonna refer them to therapy, cognitive behavioral therapy. We're gonna try to see what those triggers are. It's a whole picture. Okay. So these are our behaviors: mania, hypomania, rapid cycling. Let's go over that. Okay. So mania, elevated mood, often described as expansive and irritable. This is where this is the first stage. Okay. In my later slides, I have signs and symptoms of what that means. So don't stress about it just yet. So requires hospitalization. They have to be hospitalized because of safety. Manic episode lasts at least 1 week. That's how you know your patient qualifies to be considered manic. Remember I said Demi Lovato? Her manic episode was where she wouldn't eat or sleep for days, for weeks, right? Just write music, write lyrics, and write music. That was her manic episode, okay? And as soon as her surrounding people found out that this was the case, that's how she got hospitalized, right? Elevated mood, often described as irritable and expansive, right? On edge. Then we've got hypomania. Okay, less severe than manic. Less severe episodes of mania that last at least 4 days, accompanied by 3 or more manifestations of mania, which we will talk about in later slides. Okay, so the difference between mania and hypomania is the time frame. I know it sounds like they're like not so manic. Yeah, that means not so manic, but it's not the opposite. It's not depressive yet. Okay, it's just time frame. Days accompanied by 3 or more manifestations of mania. Hospitalization isn't necessarily required because your episodes are shorter and your patient's less impaired. But if, I'm sure at this point your patient's possibly on meds, right? This individual, if they don't abide by, this can lead to full-blown mania. Okay, are we good on this, guys? So far, so good? So far, so good? Acknowledgement? Okay, rapid cycling. This is the one where it alternates. 4 or more episodes of hypomania or acute mania within 1 year. They're alternating. Kind of hard, kind of tough. Okay? Kind of tough. Now let's talk about the types. Bipolar 1, bipolar 2, cyclothymic disorder, and cyclothymic disorder. Let's go over it. Bipolar 1 is the most difficult to care for. In what sense? Okay, Client has at least one episode of mania alternating with major depression. We've got our depressive symptoms now, okay? Lots of acute, it's a very acute type of environment, okay? Client has at least one episode of mania. Remember, mania episodes last at least a week or more. Imagine that. And they alternate with major depression. All the symptoms we've discussed last week, sick caps, remember? That's what it is. They're not new depressive symptoms, they're the same. So they alternate labile mood, okay? Severe mania and depression, okay? Oftentimes I hear doctors say that this is the worst one. This is the worst one. And we've got bipolar 2. With bipolar 2, these episodes are shorter. It's not full-blown mania. This is the hypomanic, right? Client has one or more hypomanic episodes alternating with major depressive episodes. It's not full-blown yet, okay? So it's not manic episode, it's hypomanic episode, yet it still has the depressive symptoms. The episodes are shorter, okay? And then we've got cyclothymia, okay? It's not extreme, they're functional, okay? Has at least 2 years of repeated hypomanic manifestations that don't meet criteria of actual hypomanic episodes, alternating with minor depressive episodes, okay? Although it's at least for 2 years and it's repeated hypomanic manifestations, it's not severe enough to be actually classified as hypomania with depressive episodes, okay? They're functional, it's not extreme, okay? Okay, maybe outpatient. Now, at this point, we already know that it's never standalone. They're never standalone diagnoses. Substance abuse, Demi Lovato, right? She was on what? Benzos, cocaine, a lot of stuff, alcohol, right? I'm sure anxiety disorder that you can get. We haven't talked about borderline or oppositional defiant disorders yet. We'll talk about them week 7, 8, I don't even remember. Then you've got phobias and then seasonal affective disorder. All of this comes into play. Okay, when you go to your site, open up that that chart, and check out whatever other accompanying comorbidities they have. I'm pretty sure all of this will be there. If substance abuse isn't on there, ask them. A lot of the times, our bipolar patients can't get access to their meds, so guess what they go for? Alcohol. Benzos on their own, kind of meet up with their dealers and all that stuff. It happens. I know a lot of people like that, okay? Okay, remember that diagnosis stress model? That famous diagnosis stress model, again, same thing. Genetics, physiological, psychological, substance, all these are risk factors, increases your chances. Okay, diagnosis stress model. I'm not gonna dive way into depth with this, but at this point we understand this part, right? Okay, what can cause you to relapse? So let's say, we've placed you on meds, and you're kind of stable, right? We can kind of control your manic episodes. If they utilize substance abuse, alcohol, cocaine, caffeine, this can lead to a manic episode. It's a trigger to relapse. Sleeping disturbances. How do I know if my patient isn't doing well again? They can't sleep again. Okay, we're gonna talk about it. Triggering event. You can be on your meds and stable, and then there could be some form of triggering episode, whatever that is, whether it's a death in the family, whether it's abuse, whether it's a car crash, whatever your stressor is, this can all lead to a relapse. Okay, in Homeland, I know you guys haven't seen it, but this main character who is on lithium, and there's this explosion. And that's it. After this explosion, this triggering event, she spirals down and she gets all these manic episodes. Check it out, you guys. It's really cool. Okay? All right. And then I cared for a patient one time who had her relapse. That was her. She was very functional. She was a college student. She was into all these sports and hobbies. She relapsed. by seeing a dead body. She couldn't take it. Okay, what are our manic characteristics? Labile mood with euphoria, up and down. Remember, depressive, euphoric, depressive and manic, irritable, agitated, restless, pacing down the halls constantly, cussing. This, I'm talking about the manic stage, right? Mania. I don't want you guys to get the idea that this is how they always are, because that's not the case, okay? Increase in talking and activity, flight of ideas, talking about something without stopping, and talking about a bunch of random things at once, talking about candles, coffee, TV, everything. Remember, flight of ideas, grandiosity. Sometimes they really do think that they are above everyone else. Impulsive, spending money, giving away money or possessions. So I cared for a patient one time and she was VIP. And I'm pretty sure if I mention her name, you guys will know who she is. And she was okay. She was on her meds, okay? And I believe she was on lithium from what I remember. And we were just trying to kind of taper her off of some of her drugs. She comes in with a duffel bag of cash, a big ass duffel bag with cash. And I was the one admitting her. And I had to open it up to check what was inside. And she's like, oh, yeah. Would you like some? So she took like cash like that and she wanted to give it to me, right? Kind of, excessive. Like, who would do that? Oh, I wish I can tell you. HIPAA. I wish I can tell you. You guys definitely know who she is. And I was like, no, I'm sorry. I can't take your money. And she was cool. She would buy food. No, it does not rhyme. It does not rhyme with it. No. Oh, I kind of wish I did meet her though, but it's not her. It's not her. It's someone else who's just as famous. It's not the Kardashians. But yeah, I really, really want. She even wanted to give me her coat. It was like a $3,000 coat. I was like, yeah, I wish. Okay, so spending money, giving away money or possessions. Yeah, definitely, definitely an actress. Another giving away money kind of thing. Maybe you know some friends who have some psychiatric issues. Every one of us. Now I'm making you curious. It's okay. It's the art of curiosity. Spending that money, that credit card, buying it, right? Same thing. Okay, that's impulsivity. It's a characteristic of mania. So mania isn't always aggressive, restless, agitated, irritable. It's not always the case. Demanding, manipulative. Oh, nice, Angelica. Now you're learning new stuff. I'm happy. Happy about that. Demanding and manipulative. We had a patient on the unit who was like, if I don't get an extra burger, it was burger day. If I don't get an extra burger, I'm gonna flip all the chairs in the common area. Okay? If I don't get an extra Ativan, you don't want to know what I'm gonna do. Very manipulative, very demanding. I'll do anything to get their way. Attention span decreased. Excuse me. Attention span decreased. Distractibility. Remember, they're restless. They're all over the place. I want you guys to get that manic idea. Constantly walking, can't sit still, right? You can't really, communicate with them with long sentences. Poor judgment, risky behavior, poor judgment, unsafe sexual practices. We had a few patients. I remember a few years back, one side of the unit was female, the other side was male. At the start of my shift, we saw some male patients in the female room having the time of their life. And then the next day, that same patient was in another female's room. Poor judgment. You gotta watch on my cocks, okay? So, flashy dress, makeup, and appropriate behavior. Okay. Very common. When you go to the site, please check out what they're wearing and what their makeup looks like. So, this is a form of mania. We had a patient who would do her makeup. She would take her red lipstick and that would be her blush. She would just take red lipstick and go like this, where the blush goes, okay? Black eyeshadow, one side of the hair with a ponytail, the other side was down, underwear over her shorts, bra over her shirt, okay? Flashy dress, flashy makeup. That's a form of mania, and it's funny to watch. Really, it really is. And all you can do is like, hey, interesting dress of choice. What's going on there? Okay. If they walk out naked, then I'll be like, okay, you gotta go back to your room now. Let's put your clothes back on. Come on. But if it's something that's like this, with like kind of flashy makeup and all that stuff, and if they're not combative or disruptive, we kind of let it go. But please watch them and see what they're wearing, okay? Or they'll take their top and they'll kind of make it into like a tube top, or rip it with their hands and they'll make it look like a bra top or like a bikini top. It's kind of funny. It's funny. Please watch them. Please like observe them. So that's a form of mania. Okay, so manic characteristics continue. Excuse me. So impaired social and occupational functioning. Obviously, with all those manic symptoms we just went over, what do you think? Like, you need to really watch them to be safe, right? Decreased sleep, lack of it. They can't sleep during mania. So imagine this, they'll be on lots of sleep meds too. Neglect of ADLs. Neglect of ADLs not because they don't want to, but because they're so manic. They're all over the place. They forget to eat. They forget to drink. Priority while planning. This is a medical emergency. If your patient isn't eating or drinking for days on end, come on. Your electrolytes will be all over the place. You gotta stay hydrated. You gotta eat. So when you're doing your plan of care, besides SI for bipolar disorder, priority care is food, hydration, always and forever. These guys don't eat and they have to, right? Sleep and food, very important. Possible presence of delusions and hallucinations. Think about it. If your patient isn't sleeping for weeks, what do you think? They're going to reach that delirious stage, right? They're going to start to hallucinate because they can't sleep. They're not fighting sleep, they can't sleep. And denial of illness. This is a very popular one. Nothing's wrong with them. I'm okay. I don't know why I'm here. I don't know why the cops brought me in. Denial of illness. This is a manic symptom. Right? Interesting stuff, right, guys? We good? So far, so good? Right? Okay, depressive characteristics. You guys, this is everything we learned last week. Everything. That's what it is. Flat, blunted, labile, tearful, crying, lack of energy, loss of pleasure in the things they've loved to do in the past, right? Physical reports of discomfort, somatic, kind of somatic also. Can't concentrate, difficulty problem solving, self-destructive, SI, decrease in personal hygiene, lack of increase in appetite, disturbed sleep, psychomotor agitation, retardation. Depressive symptoms, everything we learned last week. I'm not going to focus too much on it because you guys know this. Are we good on that? We're okay to move forward, right? Okay, so nursing care. What do we do? Okay, provide a safe environment during the acute phase. That's priority. What is pacing down the hall? Okay, then they start to scream and yell and cuss. F you, you be, blah, blah, blah. They take their clothes off, right? They get on the table and they're dancing in front of everyone. They take their clothes off, they get on the table. What would you do? Like, what the heck would you do as a nurse? What's priority? What's priority, guys? What is it? Get them down safely. Get them their clothes, because you don't want them to be naked. Get them down safely. Be aware of what's triggering them, okay? Talk to them, ask them. Seclusion might be the only way to safely decrease situation for client. So if you've told them to come down from the table and they're okay and they're listening to you, okay, perfect. You're not going to restrain them. But if they're still combative and nothing is working, least restrictive methods aren't working, yes, you're going to go ahead and restrain them. Remember, everything we learned week 1 stays in place. So remember, in mania, they're so restless, combative, restraint. That's correct. Remember, constantly moving, constantly talking, right? They can't sit still, all over the place. Outlet for physical activity, right? Physical activity is something that you got to utilize, but do not involve the client in activities that last a long time or that require a high level of concentration. Remember, they're already losing a lot of energy. So implement frequent rest periods, always, right? Remember, they don't eat, they don't drink. Let's not enforce too much physical activity. And when you're talking to them, straight to the point instructions. Don't give them an essay, don't give them a novel. They're not concentrating. They're not, okay? For them, it's just mouth moving. They can't focus. Protect client from poor judgment, impulsive behavior, such as giving away money and sexual indiscretions. Okay? Good, right? Good stuff. Definitely on site, if you guys have a patient with bipolar disorder, pay close attention. Pay close attention. So I kind of mentioned the self-care intervention. Monitor sleep, fluid intake, and nutrition, priority in your plan of care. So since they don't eat, right? Finger foods on the go, kind of like what you would give a toddler. I don't have kids, but I'm assuming that toddlers have a hard time eating and sitting still. So you're gonna give them chicken nuggets, sliced cheese, carrots, like the baby carrots. What else? Finger foods. What else are finger foods? Crackers. I don't know what else are finger foods. Anything that you can hold with your hand, okay? Sliced apples. That's the way to go. Okay, you're not gonna give them like a 5-course meal where they need to hold a fork and a knife. Supervise choice of clothing. Absolutely. Okay. If they're naked, and then put their clothes on. Remember the bra over the shirt, the underwear over the. Watch out for that. And the makeup too. Step-by-step reminders for hygiene and dress. Remind them, right? If they get out of their room without their top on, right? Hey, get back to your room. Let's put a shirt on. They'll be like, oh, okay. And then they'll put on step-by-step reminders because lack of hygiene, right? Are we good on this? Right? It's hyperactive is the perfect word for manic. They're hyperactive, okay? Hyperactivity. Because of that, no sleep. Because of that, no food, right? This is self-explanatory, calm, matter-of-fact, specific approach, simple, to the point, okay? Concise explanations. We don't need a bunch of lists for them. Consistent with expectations. If you're setting a limit, no, you can't cross to the nurse's station. You're not allowed to. Make sure every other nurse on the unit sets the same limit. If you told them they can't have a cigarette right now, make sure the other nurses are telling them the same thing. Limit, set limits, because they like to manipulate, reinforce non-manipulative behaviors, okay? Nurse, can I go to the common room and just like blast the music? No, you can't do that, okay? Complications. I mentioned this, physical exhaustion and possible death. So implement frequent rest periods, okay? Finger foods on the go so they can eat. A patient in true manic state, hyperactive state, usually will not stop moving and does not eat, drink, or sleep. Excuse me. This can become a medical emergency, obviously, right? That's priority in your plan of care. Safety first prevents self-harm. Decrease physical activity, implement frequent rest periods, food on the go, fluid intake, adequate, have water bottles or whatever's on the unit, promote adequate sleep, call the doctor, get a sleep med. Self-care needs step-by-step hygiene, dress, let's comb our hair, okay? And then we reach the medication management, okay? kind of like a whole picture, right? Are we good, you guys? Good stuff, huh? Interesting situation about our bipolar patients. Okay, meds. I posted 2 med sheets on there. They better be your best buds, okay? Okay, so when it comes to bipolar disorder, to target the mania, to target the manic hyperactive behavior, we utilize mood stabilizers. Very important one, lithium carbonate. Lithium, grill it into your head. I promise you, pops up on your proctor. Common question asked. Excuse me. Then we also use anticonvulsants as mood stabilizers. We're going to talk about the 3 main ones: valproic acid, valproate, lamotrigine, and carbamazepine. Okay, these 3 are seizure meds that we utilize for bipolar disorder for their manic behavior. Okay, this is what targets the mania. Okay, then we can utilize anti-anxiety meds, not for the mania, but for the behavior, right? Then we can use second-gen antipsychotics. Oh my gosh, remember aripiprazole, clozapine, ziprasidone for the behavior, right? For the behavior. And then we can also utilize antidepressants. Right? They've got depressive episodes also. We've got to target that also, right? So we're going to focus on the mood stabilizers right now. This makes sense what I said, right? Treating the manic and then treating the underlying behavioral issues. Okay, let's do this. Lithium. Okay, lithium is a mood stabilizer. It is an antiemetic. Okay, therapeutic level of mania 0.8 to 1.4. That is where I want to see your patient at. Maintenance level, where you maintain, is 0.4 to 1.2. That's where you want. Once you reach therapeutic level, it'll stay there. But therapeutic level, what I want you to know for proctored for my exam, 0.8 to 1.4. That's therapeutic level of lithium. Now, we use this to stabilize mood, to stabilize manic hyperactive behavior. Okay, when we start them on lithium, we're going to monitor plasma lithium levels because we want to make sure they don't get toxic, they don't get toxicity, they don't reach toxicity. So upon starting lithium, we monitor this every 2 to 3 days until stable, and then once they're stable, every 1 to 3 months. If the doctor changes the dosage, we're going to closely until stable and then 1 to 3 months. Now, lithium blood levels should be obtained in the morning, 12 hours after the last dose. So I administered the last dose tonight. Tomorrow early in the morning, there's going to be a blood draw because I want to know, are they toxic or not? How much of lithium is in their blood? Okay, so this is called trough level. It is when lithium is at its lowest concentration point. Okay, it's the most accurate amount of lithium in the blood at this point. This has nothing to do with being NPO. I don't care about that. Okay, it just has to be 12 hours after the last dose. Okay, effects begin within 5 to 7 days. Maximum benefits won't be seen for 2 to 3 weeks. Okay, this entire slide is like information explosion. Know this, tattoo it on your forehead. Okay, trough level, therapeutic level, all important stuff. Okay, now side effects of therapeutic level. So 0.4, 0.8 to 1.4 therapeutic level, you're going to see fine hand tremors, nausea, mild thirst, GI upset. So you take lithium with food or milk. So if my patient is between 0.8 to 1.4, I don't care. I don't care about these symptoms, okay? I just don't care at this point. I'm expecting them. I'm not going to call the doctor and say, hey, doc, I don't get it. He's nauseous. It's kind of shaky. Mild tremors. Doesn't matter. He's going to say, well, yeah, it's expected. They're at the therapeutic level, okay? Then you can gain weight. Lithium can give you diabetes. You'll feel tired, okay? Too much sodium. Not enough sodium, and thyroid dysfunction. All of these are causes of lithium, okay? Now, so between 1.4 to 1.5, we're monitoring for toxicity. We don't care yet because it's expected. The moment it goes 1.5 and above, I'm going to stop that lithium. Because this is where I'm going to get coarse hand tremors. My patient might possibly be confused. Okay? EKG changes, there might be some seizures going on. Tinnitus, kidney toxicity. Okay? Your kidneys are possibly beaten up at this point. Okay? Dialysis is started after 2.0. If it's above 2.0, oh my gosh, let's hope it's not. That means your doctor failed to place them and monitor them appropriately. They're seriously confused. Death is most likely. At this point, your kidneys are not functioning. Hemodialysis. Okay? What I want you to know is you're going to monitor for toxicity at 1.4 to 1.5, right? Fine and tremors, nausea, vomiting. You know, it's kind of getting toxic, but it's expected. Above 1.5, we're going to stop it. Okay, this is where we're going to see ataxia, coarse hand tremors, confusion and coordination, hyperirritability. Okay, so lithium, its threshold for toxicity is very, very narrow. It's very easy to hit that 1.6. So freaking easy. So that's why you got to measure that trough level early in the morning. Okay, and if it's above 1.5, stop the damn lithium. Okay. Now, oops. Okay, there's so many interactions with lithium. You're going to avoid diuretics. Why? You're going to avoid furosemide, hydrochlorothiazide. So sodium is excreted with the use of diuretics. With decreased sodium, lithium excretion is decreased. So if we don't have if we don't have lithium excretion, we can have a lot of lithium in our body, which means lithium toxicity. We can't do that. We're not with that. Okay, so we need adequate sodium and fluid intake. We need to make sure it's maintained. 1.5 to 3 liters. Okay, closely monitor sodium level. Closely monitor, and contraindicated for patients with renal disease. Absolutely lithium and renal disease. Remember, it gives you renal disease. So if they already have kidney failure or some form of kidney disease, nope. We're also going to avoid NSAIDs, ibuprofen, naproxen. We don't want that. We don't care about it. Okay, increases renal reabsorption of lithium. Remember, we want it excreted. We don't want too much of it. We got to stay up until 1.4. Okay, it leads to toxicity, decreases renal blood flow, and increases toxicity. So if they need some form of pain relief, aspirin is the way to go. Aspirin is the way to go. Okay, avoid anticholinergics, antihistamine, tricyclic antidepressants, avoid first-gen low-potent antipsychotics because they're anticholinergics. GI upset result with meds with anticholinergic side effects. So all the meds we've discussed okay? Makes sense, guys? Important stuff. Right? And interesting stuff too. Really interesting stuff. Good to know. All right, lab panel. Obviously, you're monitoring your lithium level, your 12-hour blood draw, which is called what? What is this called? 12 hours after your last dose, starts with a T, trough level. It is at its where lithium is at its lowest concentration, right? You're going to monitor your renal labs, BUN creatinine. Remember, it beats up the kidneys. And lithium causes thyroid issues, thyroid dysfunction. So you're going to monitor those levels: TSH, T3, T4. Which electrolyte am I? Which electrolyte do I care for? Sodium. Yeah. Important stuff, you guys. Now, let's say we can't use lithium, which is fine. We have all these anticonvulsants we can use, okay, that also target manic behavior. We're going to talk about Depakote, Tegretol, Lamictal. Okay? Anticonvulsants. Let's talk about the first one. Valproic acid. Useful agent in rapid cycling, substance abuse, aggression, intermittent explosive disorder. So obviously we use it for other stuff. We use it for bipolar disorder, for the mania. So there is Depakote and Terracote, which you do not crush, okay? Then there is valproic acid syrup, which is really good for patients who cannot swallow, or who don't comply with meds, or who hoard meds. Very lovely med to remember, by the way. Then there is valproic acid depakine, which is your PO, right? I'm sorry, there's depakine syrup, and there's your actual PO. I don't care about the ranges. I don't care for you to know them. Okay? So, useful in rapid cycling, substance abuse. Let's talk about the side effects of VPA, valproic acid. Okay, lithium beats up kidneys. This is all about the liver. Okay? Black box warning, hepatotoxicity, bleeding. Okay? Your liver is gonna just monitor for that. Jaundice. Excuse me. Anorexia, nausea, vomiting, abdominal pain. Excuse me, guys. Pancreatitis, teratogenicity. Okay, contraindicated for ladies who want to have babies. If you want to have children, contraindicated for you. This is something you got to watch out for. Educate them, okay? Whenever you're reading your questions on the proctored, look at the age. There's always a reason why they're telling you the age of the patient. It correlates with your answer, okay? If it's a childbearing, if the age is appropriate for childbearing women, then you know you can't give VPA, okay? So GI distress, because nausea, vomiting, diarrhea, so you give it with food. Causes drowsiness, you give it at bedtime. Tremors, okay? Usually due to anxiety, so we kind of sometimes just give them propranolol, okay? Ignore thrombocytopenia. I don't know why that's there. It's not a side effect of VPA. So delete that. It's a different side effect for something else. So VPA also causes alopecia. So we give them zinc, multivitamins with B complex, selenium. Okay. I saw selenium spray at Costco the other day. Sorry, it was specifically for people who want hair growth. Which one? Thrombocytopenia. Yeah. That was random, but I saw that there the other day. Anyway. Weight gain, obviously, clean diet, regular exercise, increased plasma ammonia, neurotoxic. Sometimes they feel blunted, drunk, delirium. Okay, watch out for that. Okay, are we good? Any questions on VPA? Yes, no, maybe so, no? I'm guessing no. Yeah, are you guys alive? I'm just checking you guys out. Sometimes I forget. Some people just have their cameras on and they're gone, and then cameras are off. I guess no points for today. And it's Thanksgiving tomorrow. Come on, guys. Aren't you thankful for me? Come on. And I'm thankful for you guys. Okay? I'm thankful for you guys. I'm thankful. Let's let's talk about Tegretol. Okay, therapeutic range 4 to 12 mLs. I don't need you guys to know the therapeutic range, but carbamazepine, given for bipolar, seizures, and trigeminal neuralgia. Trigeminal neuralgia is the worst kind of headache you can have. So you have your trigeminal nerve from the eye to like the nose area to your chin, and it feels like someone's punching you really, really hard in the eye. Tegretol is given for that. Okay, but again, we're talking about bipolar disorder. Okay, so given for mania. So this, yeah, I don't know why it was written on the other one, but so side effects: blood dyscrasias, which basically means infection, anemia, leukopenia, thrombocytopenia. So a huge risk for infection, sore throat, and report of fever. That's what your patient is going to say. Oh my gosh, my throat hurts, and then you check their vitals and they have a fever. You monitor for CBCs. You monitor for CBCs always. And this drug is the one that gives you double vision. Nystagmus, fancy word for it. Okay? Fancy word for it. The important stuff that you guys need to know. Right? Did I skip? Did I go over this? No. Okay. A bit back. So for valproic acid, remember, it beats up your liver. You're going to watch out for your liver labs. ALT, AST, LDH. Okay? The blood draw is the same. 12-hour blood draw after the last dose. You don't need to know this for my class, but Proctor know it. Okay? We just went over Tegretol. Okay, so now we have Lamictal, lamotrigine. It's an anticonvulsant used for bipolar disorder. Okay, so this one you don't want to stop. You don't want to stop any of them abruptly, but because it's shorter in life, you want to slowly titrate it. Okay, do not stop abruptly. If you do, you get Stevens-Johnson syndrome. Okay, you get Stevens-Johnson syndrome, which basically is a rash, red, itchy. I don't want to say disgusting. It's gnarly and it's painful and itchy and red, and they're just going to keep scratching and scratching. And when you assess them, it's going to be all over the chest, the back, all over the body. So, which basically means organ failure, comma, death should be the last one. They'll be kind of sedated. They'll have a headache, organ failure, dizzy, death. Okay, death. So lamotrigine equals Stevens-Johnson syndrome. You got to watch out for that. Okay. Now, there's also triliptol, also an anticonvulsant. We also use it as a mood stabilizer. This is the one with the least side effects. Again, you don't want to stop any of these drugs fast, cold turkey, because they're seizure meds. You don't want to induce a seizure, but sedation, dizziness, headache, nausea, vomiting, these are the main side effects. I guess sort of anticholinergic, sort of, a bit. Are we good? Okay, now we've reached benzos. I'll go over benzos in detail in our anxiety chapter, but these meds, we don't use for mania, we use for behavior, right? Clonazepam, lorazepam, alprazolam. It's the PAMs and the AMs. Klonopin, Ativan, Xanax. So if my patient is pacing up and down, okay? They're pacing up and down, their behavior is escalating, and I want something to work now, this is it. This is what I'm going for. It's going to work like this, okay? And then again, the atypical antipsychotics, second gen, Zyprexa, Risperidone, Seroquel, Latuda. So if they're escalating in behavior, they're dancing on that table, and you've tried least restrictive methods, and you're going to restrain them, you're going to probably call a doctor, and he's going to be like, okay, yeah, let's give him Seroquel. Let's give him Zyprexa, okay? Are you guys understanding what I'm trying to say? We don't target the long-term mania. This doesn't do that. This is behavioral, okay? Making sense, guys? More people, it makes sense, yeah? I want you guys to get that concept. Okay. So that was the meds. That was our treatment. Now, we have other treatment also. We also use ECT. If meds don't work, ECT is the one we go. Again, we don't stop the meds, but we utilize it too. Obviously, it's a multidisciplinary approach, everyone together, support groups, health teaching, families involved, antidepressants or the manic meds, right? Antimanics. It's never that alone. It's never monotherapy, okay? Unless effective in the past and has not caused mania or hypomania, right? And exercise, but with frequent rest periods, right? Which anticonvulsant med might be prescribed for a patient with bipolar disorder? Depakote, Klonopin, Zyprexa, lithium. Which one? I got some D's. I got some B's. More people. Come on. Come on, come on. Okay. So, is this an anticonvulsant? Is lithium an anticonvulsant drug? No. No. It's okay. It's okay that we got it wrong. Learning. You learn. Which one is the anticonvulsant here? This is anticonvulsant. Depakote. Remember, you got to read the question carefully, right? It's all good. Good stuff, you guys, good stuff. This one you would have to know if the dosage is right. 300 milligrams is a good dose. So, you know, now you know on your test, when you read 300, you're not going to be like, is this too much? Is this too little? Psychiatrist orders lithium, 300 milligrams PO 3 times a day for a 40-year-old patient who has no contraindications. What a lovely, beautiful patient. As an RN, you would suggest to the doctor the dose is too high. It's not. Know that this is a common dose for a patient. Suggest to the doc that the dose is too low. We don't need to increase it. Remind the doctor patient over 35-year-old cannot take lithium. No, that's not a contraindication. Okay. So for your next week's exam, there's going to be this dosage. No, it's good. It's okay. Okay. It's not this question, but it's this dosage. Okay. Done with bipolar. Good. Are we good on this? Interesting stuff. Yes. Yeah. All right. Let's take a break. I think let's take a break.